Kind words. Happy birthday to the Detroit Recovery Project.
Yeah.
I am thrilled to finally be able to come here and see what has been built, because Dr. Johnson has such a reputation in our field. I'll tell you, the person who hired me at Harvard Medical School and the founder of the Recovery Research Institute talks about him with the utmost respect. The day I put your book in his hand and I said, I brought this to you from Chicago, he was so touched. And he said, I'm going to call Andre. So it's just a pleasure to be here. But I am grateful for everybody who showed up today. I love seeing these people. Look at these groups. I just want to get down to it for sure. I want to also thank the Center for Addiction Recovery Support, who actually has be the people who sponsored me to come here today. This is a technical support center that's led by people with lived experience, and at the end I'll show you their QR code in case you're interested in more resources from them as well. And although, next slide please, my slide beeper doesn't quite work, so I'm going to call next slide. And although federal funding is quite important, it's also going to be why some of the words are blanked out on my slides today. I'm just going to say it. We lost some of our freedom of speech. All right, and when you involve federal funds, my work is now being centered. To talk about race is banned when federal funds are involved. My line of research is defunded, unfunded. And so I will proceed with the best that I can using our time here today. Now, next slide. But I want to start with a nod to harm reduction. I really must. I, as a scientist, love to work through evidence. Right? Research is one form of collecting evidence. And before I go into my usual spiel that I crafted specifically for you, I want to tell you about this one most interesting study to me that's gotten a ton of attention from leading scientists in this field. They did what they call a simulation model, and they asked the question, what is the most impactful way to reduce overdose and to reduce the prevalence of opioid use disorder? And they considered like 11 different approaches in their model. They took real data, projected it out 10 years, all the way from prevention to increasing treatment capacity, upping the limits. But the three things that were the most impactful in this incredible simulation model were the fentanyl-focused harm reduction services, number one. Second, increasing naloxone distribution for people who use opioids. And third was recovery support services, and that had the biggest impact on long-term outcomes. Okay, and so I want to tell you that that was an incredibly important study. It supports that we must be integrating harm reduction services if we are going to have an impact. Now, I think that any credible conversation about drugs and race has to acknowledge the role of drug policy, despite the fact that I, for example, work at Massachusetts General Hospital, I work in healthcare. I think we also have to acknowledge the role that drug policy has played. And when you think about it, all drugs were once legal before they were illegal. So you have to ask yourself, what happened, what changed that made something illicit? And it's not necessarily based upon pure scientific assessment of the risks and benefits of a drug, but it often had to do with who was perceived to be using the drug. Right? And so you can see here in the 1870s, anti-opium laws that were motivated at Chinese immigrants. 1910s, 1920s, anti-marijuana laws directed at Mexican migrants, Mexican Americans. And in the 80s, we had some important crack cocaine laws that were directed at African American communities. Next slide, please. The ones that came out in the 80s were particularly notable because this was the linchpin policy that filled the prisons with Black and Latinx individuals. It was those drug policies specifically stemming from the Anti-Drug Abuse Act, meaning, at least the best numbers that I can get my hands on, we have African American and Latinx making up 77% of those incarcerated in federal prison. African Americans only make up 14% of the population. And 57% in state prisons. This produced the mandatory minimum sentencing, 5 years to life. It really tied judges' hands in that regards. And it had this incredible disparity in federal penalties for crack versus cocaine powder. Chemically, this is the same drug. The difference was who was using it. 100 times, you can see the same penalties for the possession of crack cocaine as 100 times for the same amount of powder cocaine. Next slide. This was not an accident. This is a quote from the architect of the war on drugs. He was Nixon's right-hand man, and he gave an interview in the 90s talking about what was motivating this, a very public interview. And he said, the Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. We knew we couldn't make it illegal to be against the war or black, but by getting the public to associate hippies with marijuana and blacks with heroin, then criminalizing both heavily, we could disrupt the communities, we could arrest their leaders, raid their homes, break up their meetings, and vilify them on the evening news night after night. Did we know we were lying about the drugs? Of course we did. Next slide. So you have to understand that in our country, we have had a number of tools, historical tools that were used as a form of racialized control. You go back, you can see that slavery was replaced with the Jim Crow era, where legal segregation in hospitals, schools, restaurants, banks, it was even allowed to be illegal to loan to African Americans. The banks, the beaches that I sit on Cape Cod right now, I'm from Massachusetts. My grandmother was not allowed to be there because there were signs from the government prohibiting people of color. And then we have the Jim Crow era was replaced with mass incarceration of people of color that was fueled by the drug policies. That was the linchpin populating at that time. Now our national drug control strategy has now extended well beyond where it was years ago. We now don't just have international policies and are leaning on criminal justice. We have treatment and recovery support. We have learned a lot from this time. Next slide, please. We have learned a lot since then. In fact, when you think about, really we went from, as the title of the talk was, from crime to the clinic to the community, and this kind of changing public health approach. The advances that were made that we actually recognize substance use disorder as a treatable medical condition led to many life-saving psychopharmacotherapies and psychosocial interventions. However, medical mistrust is high amongst individuals in general, and it is particularly even higher, and we know this from the research, in communities of color, right, to approach and to use medical systems. In fact, next slide please, we can even use the research to specifically identify where racial health disparities are perpetuated in the treatment of substance use disorder. And so I'm going to bring to you some of just the most prominent research that has specifically found the locations by which we start to know where to target. Next slide, please. So if I kind of lay it out on this timeline, because it's abbreviated, I'm not up here for too long today, we're just going to focus on the course of illness for severe substance use disorders, mainly on the help-seeking phase. But I could talk all day about the before, the addiction onset, and the full sustained remission after. We're going to focus on help-seeking. Next slide, please. This is national data from the Center for Disease Control, right? This represents the entire general population in the country. They found that black patients have a 20-year delay seeking treatment for heroin compared to their white counterparts. And national data was showing us that black individuals were getting into care between the age of 45 and 49, while white individuals were coming in between the age of 25 and 29. And it didn't matter if you added gender into the equation, it was still the same effect. We have a 20-year treatment delay. Large levels of medical mistrust are happening, as well as, instead of being inundated with treatment, recovery support services, harm reduction, we are having a lot of drug policy effects on this, disproportionately on this community. That's another reason why we're seeing such delays. But that's an important thing for us to notice. Next slide, please. Additionally, New England Journal of Medicine, this is our top, most prestigious journal. It took years of accumulating evidence before finally coming out in this. We've seen this over and over again, but finally, when it came out, white patients were receiving medication after an average of 6 opioid use disorder related medical visits, 23% of the time. Given what we know about the efficacy of the medication, in general, we consider that to be low, okay? But 23% of the time, after 6 times coming in for help, compared to 18% of the time for Hispanic, and half of that for Black patients, 12% of the time, they were getting access to the medication for opioid use disorder. Next slide, please. That same study found the exact same trend when it came to the co-prescription of naloxone, overdose reversal. The exact same trend. We're coming in about 23% of the time for white patients, which is low. When you have somebody, 6 times they're coming in, we need to get naloxone in much sooner than that. About 21% of the time for Hispanic patients, and half of that for Black patients was about 13.9%, 14 for Black patients, okay? So naloxone co-prescription, the exact same trend. Next slide. Now we're going to look at what they call an effective dosage. This had a big operational definition, medically speaking, but basically we're talking about 8 milliliters of buprenorphine, otherwise often known as Suboxone, okay? So this entire sample of claims, about at least 90% of people actually met that criteria, but when they looked at it by race, they're finding that Black patients were 21% less likely compared to white patients to receive that effective dosage. Hispanic patients were 11% less likely than white patients to receive an effective dosage. These were significant differences. Next slide, please. This study also looked at what they called a sufficient duration. Again, a lot of details, but basically you're talking about a 6-month time period with minimal interruption, no more than 1 month. Black patients were 36% less likely to receive a sufficient duration of the medication compared to white patients, and Hispanic patients were 26% less likely to receive it for a sufficient duration compared to white patients. Next slide, please. Why do we care about this? There's been some good news put out there recently. The Center for Disease Control, for the first time in decades, has started to tell us that fatal drug poisonings have actually started to decline. We haven't seen this in a long time. In fact, I think it's up to almost 27% at this point. It is not true for groups that are not white. Okay, so that's what you get when you disaggregate the data. And their rates were going up in this study that looked at that same data. White overdose rates are going down. There's a lot of reasons for these things. We don't have time to go into that stuff, but sometimes new interventions and new technologies in a society that is socially imbalanced tends to favor certain groups first, right? But this is what we're seeing right now on a national level. Additionally, you should also know, which we've known this, several national studies have told us that African Americans are half as likely to remit from either an alcohol use disorder or a drug use disorder. That's in the general population. You get them into treatment, it's a different thing. But in the general population, they're half as likely to remit. So what we just looked at here is we're seeing that the groups that have rising overdose rates are the least likely to get medication, the least likely to get overdose prevention. That's why we pin these points down, because we look at our healthcare sector and people in that and we say, what can you do to help fix this? We want you to know about this, right? Let's start working on these issues. Next slide, please. But we don't want to throw the baby out with the bathwater. Okay, don't want to throw the baby out with the bathwater. That's why the final thing I want to say about when it comes to this medication section is, what do we even know about the efficacy of this medication, okay? Besides the fact that most people with opioid use disorder are not on it, okay? And so that kind of tells you about the way we're able to attract and engage people in healthcare. But what you need to know is that here was this was the largest study done of individuals who had a prescription opioid dependence, okay? They studied different lengths of treating them with buprenorphine, also known as Suboxone, and then you pull them off the medication and you see what happens. It's one way of seeing and tapping the efficacy of the medication. Of these over 600 people in this trial, they defined success, if you will, as either abstinence or near abstinence from unprescribed opioids. What you find here is, okay, let's put them on the medication for 4 weeks and then we taper them off. What happens? 7% success rate. All right, so let's keep this group on for 12 weeks. We will maintain them on the medication. What happens if they're still on it at 12 weeks? It jumps to nearly 50, almost half of a success rate when they're maintained on the medication. But then when you pull them off at 12 weeks, it jumps back down to 9. That kind of gives you an effect, a reason of why we don't throw the baby out with the bathwater and why we consider this to be a life-saving intervention. Next slide. In fact, The follow-up, years later, this is years later after that study ended. People could do what they want. They could use medication, not use medication. Maybe they were using drugs. The point is that if you look at this graph, the blue and the red, which total 60%, years and years after this trial ended, 60% were not using unprescribed opioids at that point, right? So we're looking for long-term outcomes as well. Right, and then there's a mix of people who chose to use, who are, maybe have been using medication or not and still struggling with substance use. Is it a perfect bullet? No. Is it something that's very powerful considering what we're dealing with, substance use disorders? Absolutely. Next slide, please. But let's go on to these community-driven approaches, right? Because we are now seeing a shift. The community approaches have some of them have been here for a long time. They've been here for a long time because SUD wasn't even really embraced in medicine. It wasn't embraced in medicine. So they built up on their own. Grassroots organizations built up on their own. But now we're seeing a real movement, a real merger coming through here that we haven't seen before. What it gives us is the community-based services are giving us the ability to plan. We've got to plan for the short term and the long term. Next slide, please. We're learning a lot about course of illness and recovery when it comes to this health condition. But I'll point you to the black box first. 70% with individuals with addiction will achieve a full sustained remission. This is something that we generally consider to be a good prognosis disorder. There is hope. There is actually hope. This is important for people to know because when we see only what we see in our jobs, if you're working at the detox center, right? If you're working in the outreach program, you start to see a lot of the same thing. But you need to understand that this is real, life can get better, the odds are in your favor. That's what you can tell people. The odds are in your favor. But what do we know about this? We know that after help seeking begins, this could be whether it's treatment, community-based services, it takes about 8 years before the people who will enter remission do, on average. After that, after a full sustained remission, right, that's when it takes an additional 5 years before the risk of meeting criteria for substance use disorder drops below 15%. Why 15%? Because that's when you're no more likely than somebody in the general population to have a substance use disorder. Risk remains elevated for quite some time. Another reason why we are rethinking the infrastructure for substance use disorders, realizing that we need to extend the continuum of care with community-based services in different ways that will now map onto what we know about course of illness. Our approaches of detox and 12 months of treatment do not map onto what we understand about this illness. That's why we are restructuring our approaches, because we can accelerate this timeline, and we're seeing services that accelerate this timeline when we know where we're at, what we're dealing with here. Next slide, please. In fact, this is part of why I like to give people a clear view of the treatment versus the community support services, because I get emails, right? I get emails and they say, I want to open a recovery community center in my community. They're telling me that treatment is here. Why would we need to do that? Okay, so I put this together so people can have the words to make the case for the work that they are doing. These are not duplicative or overlapping services necessarily. What we know, we use treatment to reduce symptomology, pathology. We are looking for the goals of community services to address social determinants of health, housing, jobs. They remove institutional barriers to care. That is an evidence-based fact right there, that peers are doing that. Reducing isolation, increasing social engagement. The time frame, short term, but one we can use for the long term, the whole way through. Insurance will only pay for your treatment for so long if you're doing that, right? It's very short term. We can't expect people to always come into a major healthcare setting like where I work at. We've got to go into their communities, particularly with people with medical mistrust. You've got to go into the places where they eat, live, play, where their families are. That's where we have to be if we're going to make a bigger dent in this problem, particularly for people with medical mistrust. The providers are different. We're not leading with clinicians alone now. We've learned that we've got to pair with peers. Again, helping to navigate issues of medical mistrust. There are different providers and different services. Next slide, please. So I wanted to take just a bit of a deep dive. I want you to look underneath the hood to kind of see what I see when I'm looking at, is this service effective at helping people? phenomenal. I have a lot of different services I could choose from, particularly in the recovery support sector. I chose recovery housing because it's my latest publication. So we're going to take a look at this service. There's a number of recovery support services out there, though, that we can take a look at. So I want to take a look at this particular service. In this case, we're looking at something that is abstinence-based, supportive living environment. You might have heard it, sometimes it's called sober living homes. It goes by different names, but it's kind of the same theme with different models. But it's also important to understand that there's a lot of peer decision making here. There's different levels of support. Okay, they're not all the same. They can be peer run on their own. The peers run it. You can also have a house manager. A peer might serve as a house manager. They can be supervised. They can even have clinical support in them. Okay, so that's the first thing to understand about this level of service. They are the most widely available recovery support infrastructure in the United States. They're in the National Drug Control Strategy. And it used to be the wild, wild west with recovery residencies, but there's a degree of oversight. Like when I talk with people in the medical field, they want to know, is there any quality control? Is there any oversight? They're used to thinking about things from their perspective. Yes, there are. The National Alliance of Recovery Residencies, you have a state affiliate here. They provide certification. That way you know if you refer to a certified home that, let's say, they will allow medication and they won't tell them they're not allowed to take medication, right? So there is a way of saying, oh, is this home certified? Okay. Next slide, please. So basically, this is what we did. I just published it this spring. I went and reviewed all the published literature on recovery residencies. It was like thousands of studies and assessed a lot of full text articles, but there was only 5 studies that did what I needed it to do, and that was compare people who went to recovery housing to people who did not go to recovery housing over the long term and see what happened. We used there was a number of what we call randomized controlled trials. We just do that so the groups are balanced. So you don't have one group that, well, they had a lot of comorbidity in that group. That could have been what caused it. No, we balance the groups because we want to be able to say that recovery housing caused that outcome. It's very important for us to get causal effects, or what we call quasi-experimental designs. But the point is there's a comparison group. There's only 5 studies that met this criteria to assess the evidence of the effectiveness for this service to determine where it falls. Next slide, please. I'll pull this study out first. This was simply called recovery housing in the literature. There was about over 250 people in this study. It was over 68% African American. And what you'll see is that after leaving detoxification, or medically managed withdrawal is what they call it today, but after leaving detoxification, the people who went to usual continuing care. So after detox, here's a list of services in the community. Good luck to whatever decision you make. See you later. At 6 months, they had abstinence rates of 13% only. But for the group that was assigned to recovery housing, this was abstinent contingent. So the investigators actually paid their rent when they had negative drug screens. Okay? At 6 months, 37% were abstinent from both cocaine and opioids. And then when you threw in treatment, it was 12 weeks of treatment, but most of them did not do 12 weeks of treatment. They got these effects with just a couple weeks of treatment. It boosted to 50%. All right, so that's what happens when you kind of look at the hood, and that was at 6 months. But the next slide I'll show you, next slide please, shows much more long-term outcomes. Now we're looking at 2 years out. This is well after most people have even left the house on good terms. And so we need services. What shows persistent and lasting effects long after the intervention is even gone? That's what we're going for here. I only put anything up on the slide if one group outperformed the other. That's the question of comparative efficacy. The red check mark tells you that it was in favor of the Oxford House. So when you take a look at this, you can see that when they were randomized to either usual continuing care or the Oxford House, substance use, meaning their abstinence rate 65%, we're talking like 2 years down the line compared to only 31% when they had continuing care as usual. The Oxford House doubled their monthly income. The Oxford House cut what they called criminal behaviors down to 1/3 of what it was when they didn't use the Oxford House, okay? And the net benefit per person, $29,000 favored per person per year in favor of the Oxford House. That cost to benefit analysis was mainly because of reductions in the criminal engagement. That's where the cost to benefit analysis showed through. But you can also see when they compared it to a therapeutic community. So this is a really active comparison. It's hard to outperform an active comparison. Therapeutic communities are also residential settings. right? So you might expect similar outcomes, but you can see still a peer-run home was doing better than a therapeutic community. The abstinence from alcohol was at 66% 2 years later, compared to 40% of those who went to the residential community. I did notice that I saw that for alcohol. I did not see that change for other drugs in this particular model of house. I also see the social network favored the Oxford House, meaning how many people in your social network are heavy drinkers versus how many people are more on the recovery side. Again, that favored the Oxford House. Doubling their days of work, cost to benefit analysis, you can see the therapeutic community cost a negative $7,500, okay? But yet was still outdone by this. The next study is very important to me because all of these women came from incarceration, okay? And so hundreds of women with incarcerated backgrounds, we're talking about samples that have high psychopathology, high trauma, low recovery capital. What can we do for these people? The first thing I see when I look at that study for 2016 is a lot of blank spots. I'm looking at this, I'm thinking the Oxford House for this group doesn't appear to really be benefiting them compared to usual continuing care, with one important outcome though that I wanted to note, and it was mortality. The people who went to the Oxford House 2 years later had 0 deaths compared to those who were at continuing care as usual. 4 people died in that condition. So what you're looking at here is potentially a life-saving intervention for women coming out of incarceration. But still, more work needs to be done. We want those women having some of the benefits that we see in all across those other studies as well, okay? But as they say, you can't treat a dead person, right? So mortality is an outcome that these peer-run homes can help with. And again, the last study was, again, incarcerated women. And what they did see a change in substance use on this one, negative, decreasing by 10 days, but going up in the other ones at the 2-year follow-up, increasing by 12 days a month of substance use, increasing by 14 days a month their substance use did at the 2-year follow-up. So next slide, please. Recovery housing is an abstinent-based model. Okay, it is an effective service on the continuum of care. At the same time, we're trying to build an infrastructure that is safe for everybody. And what happens is people have become concerned. What if they have a return to use and now they're not in the recovery house anymore, right? And now what if they're homeless? And we don't want that. And that's why the federal government, for example, at SAMHSA, I went down and participated in this meeting and this document they drew up. They're trying to understand better and advise people on the intersection of housing first versus recovery housing, okay? Housing first, they're not the same thing. Okay, housing first is not there to get you into long-term recovery. A successful outcome in housing first is considered taking somebody chronically unhoused and now they have long-term stable housing. That's what's considered success, regardless of drug use. Okay, and I will say, just for the record, housing first, the science is clear, has 0 effect on symptomology of SUD and mental health. Okay, now that being said, it's a human rights issue. Getting people housed, right? That's why we need stuff like no wrong door, right? Normally recovery housing might be isolated over here, but we need people to establish a little bit better intake systems where no matter what door they enter, they can get a warm handoff to whether it be the housing first infrastructure or the recovery housing infrastructure. We need choice-based screening tools to allow for these decisions to be made. We need to start funding the coordination of care, not just the direct service itself, because these services need to be coordinated so people don't find themselves on the street, okay? And peer respite homes, right? Abstinent-based and non-abstinent-based, they can be co-located, but this whole report was getting at better intersecting these services so we can build a better continuum of care or a better continuum of care for housing, depending on how you look at that in general. Next slide, please. So, summing it up, we're all done here right now. Where we've been is that we talked about this shift from incarceration to the clinic to the community and broadening our approaches and the things that we've learned along the way since policies going way back. And we talked about certain drug laws that were the linchpin of overpopulating prisons with people of color. Overdose rates are climbing in non-white communities, yet decreasing in white communities. And we can do something about that also by identifying specifically where healthcare disparities are perpetuated in the treatment of SUD. and the community-based strategies are our opportunity to plan for the short and the long term, which is what we need for this. And if anybody would ever want to follow up on the idea of, my boss wrote this in the New England Journal of Medicine recently, the changing approach to addiction, incarceration, treatment to recovery, sport kind of inspired the outline of this talk, except I give you the look at race through a racial lens as well. Thank you very much.